Hello, everyone. I'm Carol Fleck, and on behalf of the ADDitude team, I'm pleased to welcome you to today's ADHD Experts presentation titled The Unspoken Truths of Postpartum Depression, Help for Women with and Without ADHD. Leading today's presentation is Dr. Jayne Singer. Dr. Singer is a clinical psychologist and endorsed infant and early childhood mental health clinical mentor. She has over 40 years of experience working in hospital and community-based programs that serve children and families with developmental, medical, social, and emotional challenges. As many of us know, there are few transitions that are more life-changing than having a baby. Add in the wild hormonal swings that come with pregnancy and childbirth, and it can turn a household upside down. It's not uncommon for postpartum mood changes to affect new mothers and even caregiving partners. In today's webinar, we'll learn how to identify the warning signs of depression after childbirth. And we'll also learn about the kinds of support and recovery new parents need to be healthy and thrive. We'd like to begin today's webinar by asking two poll questions to our live audience. If you've experienced postpartum depression, were you given a diagnosis, or did your doctor miss your symptoms? And the second question, would you be able to identify postpartum depression in yourself or in others close to you? Please select your answers and comment in the text box under the video player to tell us more. For answers to common webinar questions about slides, transcripts, and certificates of attendance, click on the FAQ tab of your webinar screen. If you're listening in replay or podcast mode, visit ADDitudemag.com and search Podcasts 470 to access the webinar resources, or simply click on the episode description where you stream your podcasts. And if you support the work we're doing here at ADDitude to strengthen the ADHD community, we encourage you to visit ADDitudemag.com/subscribe and sign up for ADDitude Magazine. Our new fall issue offers advice on how to help your child succeed at school, and for adults, tips to up your value at work. Subscribe today for yourself or to share with a teacher or a loved one who could benefit from greater ADHD understanding. Click the magazine tab on screen to learn more. Finally, the sponsor of this webinar is Inflow. Inflow is the #1 app to help you manage your ADHD. Developed by leading clinicians, Inflow is a science-based self-help program based on the principles of cognitive behavioral therapy. Join Inflow today to better understand and manage your ADHD. Click the link on screen to learn more. ADDitude thanks our sponsors for supporting our webinars. Sponsorship has no influence on speaker selection or webinar content. So without further ado, I'm so pleased to welcome Dr. Jayne Singer. Thank you so much for joining us today and for leading this discussion.
Well, thank you, Carol, and I want to express my gratitude towards ADDitude and the sponsor for having me today. This is a topic that is of tremendous passion and interest for me, so I am very grateful to be here with all of you and all of you tuning in to listen in. I do want to start with this comment here that today's discussion is certainly not meant to provide or replace any guidance that you're receiving or you may choose to pursue receiving from your medical or healthcare provider. So if you are tuning in and you are someone or you know someone who needs urgent support, I'm just starting with this slide here with several resources for your immediate use. That can help you, particularly if the signs, the symptoms that you might be experiencing are in urgent need of a response. All right, so today we're going to be thinking together about postpartum mood disorders, and yet I think you're going to notice pretty quickly that I'm going to be coming at this discussion from the angle of infant-parent mental health, meaning the health of the relationship. addressing the health of the relationship between a birthing parent and their baby as being a critical target of our attention and our intervention. We can easily say, under any circumstances, that managing our strong emotions within ourselves, within our relationships, is a lifelong developmental process. And that process is pretty essential to our own well-being and to the well-being of our loved ones in our families. So I'm starting here because I have worked with so many women truly suffering in the postpartum period who received some initial advice to distance themselves from their babies, from their infants, because of the advice that postpartum depression, for example, is not good for the baby. However, a new parent receiving the message to distance themselves from their infant can be devastating, especially to a new parent who's struggling already to feel connected to their baby and struggling with themselves, their sense of themselves as a competent parent. And so I start with this beautiful quote from Donald Winnicott: "There's no such thing as a baby," right? A baby only exists as part of a relationship. And every family also does not exist in isolation. A family exists, and the relationships in the family exists within a wider extended family, community, neighborhood, culture, and society. So what does that have to do with today? What we know is that as young children develop, their emotional experiences literally become embedded into the architecture of their brains. So it's really critical as we start to get our minds around thinking about postpartum experiences, postpartum mood disorders, to remember that the baby also makes a contribution to the relationship in that postpartum period. So as the parent, a new parent, is establishing their own sense of well-being, the baby is making a contribution to that well-being. So just take a moment and take a look at the two pictures that I have on the screen. And what do you notice between the two different pictures? It's very easy to see the picture on the left and say, "Oh, how lovely and wonderful," right? The mother is smiling. The babies are content. One of the babies is already reaching and looks like they have an early smile. But you also know that babies are not in that state of being all the time. And in fact, very early on in infancy, there is a lot of crying, right? So it's critical that we think about the contribution that the newborn makes, and that new parents need even more support when their infant happens to be a more fussy baby for reasons maybe related to the baby's temperament or sometimes other physiological reasons. So just as infants don't exist in isolation, they cannot develop by themselves, we as parents are also not designed to do this alone, right? Children need at least one adult to fall in love with them. Parents need at least one other person, another adult who supports them and champions them. And these are some of the critical elements of what we think of as being infant mental health, or I would say infant parent mental health. So just take a look at this list. The physical and emotional health during pregnancy, the physical and emotional health of the birthing parent, pregnancy and the postpartum period is a critical piece of or source of influence upon the well-being of the child. We know this, and yet we as a society need to do better to support that transition for infants and for their parents. So what we're really talking about is what some of us in the infant mental health world like to think of as the fourth trimester, the period of life covering the first few months after a baby is born. That period consists of several life-changing transitions for the baby, getting accustomed to living in the outside world, for the parents, getting accustomed to the baby and accustomed to being parents, and a critical period for that emerging relationship. For the baby, there's lots of what we call biobehavioral shifts in their behavior, in their state regulation. What do I mean by that? At any given moment, a new baby comes in one of 6 possible different states. They're either deeply asleep or light sleep, or maybe they're drowsy because they're falling asleep or they're coming awake, or they're quietly alert and awake, or they're fussy, moving up into full-blown crying. And at any given moment, they're moving back and forth between these different states during a period of very rapid brain development. For parents, this first few months, this fourth trimester, is a really formative stage in a transition to becoming a parent, even if the baby is not their first baby. It's a sensitive period of time in establishing relationship. For those of us who have the privilege as providers of working with families during this sensitive stage, this fourth trimester is also a pivotal period in our developing a relationship with the family. Arietta Slade, who is a wonderful parenting and infant development expert, often writes about this idea that in our society, right, pregnancy, parenthood are often expected to be experienced as happy and joyous, right? Expecting parents will hear from people, oh, you'll never know love like this before, or you're going to fall deeply in love. It's the deepest joy I've ever, right? All of these messages. But in reality, ambivalence is pretty common, not only during pregnancy, but also once the baby is born. Every parent after a baby is born is in a state of potential disequilibrium. What does that mean? Like just being thrown off course and reorganizing during this transition to parenthood. And that comes with many opportunities for development and relationship and possibilities for crisis. Many women who have told their stories to me, many of the stories that you hold yourselves or that you've heard, include people talking about how differently they felt after their baby was born compared to how they had hoped or expected they would feel. And I'm not just talking about mothers, right? I'm talking about birthing parents, partners, and we also know that in this critical period that we all ourselves as adults, whether we are parents or not, we were parented at some point. It's human nature to have our experiences of our own childhoods somehow become a little bit reactivated by becoming a parent. I'm going to keep coming back to this idea, right? That before the baby is born, we often engage in imagining who the baby might be. Maybe there's a wished-for version of that baby. Maybe there's a version of that baby that's a little bit more frightening to think about. We all hope for the health of the baby. And then along comes the real baby, right? Most expecting parents, when they're expecting a baby, are imagining, are picturing a baby who's maybe already 3 months old, smiling, cooing, interacting. Not necessarily picturing a newborn, right? And the reality of the newborn, the level of neediness, the level of crying, the level of disruption to day-to-day routine, the level of disruption to sleep for the parent, right, can easily be quite overwhelming for any parent. That's true under the most ideal of circumstances. Now, what about when those circumstances really present some more significant emotional challenges to any of us as parents, that's when we might see or experience something like a postpartum mood disorder. So postpartum mood disorders, they typically onset within the first few weeks following birth, but not always. Sometimes the onset may occur much later, still typically within the first postpartum year, but not necessarily in those first few weeks. We think about a postpartum mood disorder when we think about the experiences, strong feeling of anxiety, even panic, sadness, crying, tiredness, even hopelessness, that's lasting for days on end. We're not talking about sort of the momentary or little periods of time. We're talking about this prolonged, continuous, right? Days on end, might even consist of irritability, anger, rage, right? And those are some of the emotions. Some of the thoughts might really include resentment towards the baby, resentment towards family, resentment towards a partner, self-criticism, guilt for even feeling those things, feelings of being unsuccessful with the baby. And again, this is where it's critical to think about the contribution that the baby makes, because some babies really are more challenging to care for. Some babies are quite well regulated in how they manage their different states, and some babies have much more challenge, right? These prolonged periods, feeling down, can really lead to a feeling of being disconnected from the baby. It's really important that we understand that, yes, of course, one of the major contributing factors to this is the hormonal changes for any birthing parent. And by the way, caregiving partners also experience hormonal changes and brain changes in addition to the birthing parent. But the hormonal changes are not the whole story. There's sleep deprivation. There's the emotional transition to meeting and understanding who the real baby is. There's isolation that families or individuals might experience, adjusting to a new lifestyle, adjusting to a new identity, right? Like I said before, feeling unsuccessful. Oh, I'm trying this, I'm trying that, I'm trying this. It doesn't feel like it's working, right? Parents have often talked with me about feeling disregarded, meaning all of a sudden after the pregnancy, all of the attention is going to the baby rather than to the birthing parent, and feeling dismissed, even bringing up the concerns. I'm crying, I'm not feeling the way, and getting some messages back of, oh, that's just the baby blues. You'll be fine. It's just the baby blues. Add on top of that the pressures that so many birthing parents also experience about the return to work, right? And childcare decisions and arrangements. Last but not least is the friction that birthing parents might experience in their parenting partnership, or lack of partnership if they're doing it largely on their own. So many postpartum birthing parents feel all of these influences. That's why it is really critical to screen everyone for postpartum mood disorders so as to prevent worsening symptoms. So what are postpartum mood disorders themselves? So I mentioned baby blues. That's a very common experience right after birth that seems to be associated with that initial hormone dip, right? And it can certainly feel like sadness and sleep disturbance, irritability, anxiety, tearfulness. That the baby blues seems to peak sometime within the first week after birth and lasts for maybe another couple of weeks. And the majority of parents, birthing parents, do experience some version of that often resolves on its own if the family has enough social support. Then there's postpartum depression, okay? And we might say that maybe 10, 15% of postpartum people go on to develop a full-blown postpartum depression, but that's likely an underestimate because a lot of the studies have only looked at the first few weeks postpartum, and sometimes the postpartum mood disorder does emerge much later, right? Sleep troubles, right? You've gotten the baby back to sleep, but you yourself cannot fall back to sleep. Depressed mood, sadness, a loss of interest in activities, especially activities that used to be enjoyable, weight loss or weight gain, restlessness, or the opposite, slowing down of movements, right? Fatigue, fogginess, feelings of worthlessness or guilt. All of that deserves immediate professional care and sometimes medication, and we're going to get to that as well. But there are other postpartum mood disorders as well, postpartum anxiety. So most people who experience postpartum depression also experience clinical levels of anxiety. Every new parent, of course, is worried about the fetus during pregnancy, is worried about the newborn baby. But postpartum anxiety disorder is much more amplified than that. It occurs when those worries become excessive. They become uncontrollable. I can't put it out of my mind. I'm worried that the baby's not going to gain weight, or that the baby's never going to sleep, or. We say that it's a postpartum anxiety disorder when the worries, the excessive anxiety is really interfering with daily life, interfering with taking care of the baby. The worries might be about the health of the baby, might be the parents' worries about their own health or the health of their partner, worry that their partner might die, or that they themselves might die and leave the baby without a parent, right? Really intrusive worrying, which can include panic. If social anxiety is involved in the postpartum anxiety disorder, that might actually also include some pretty extreme fears that someone might have, that they're going to be socially judged. Judged for their parenting, judged for not feeling happier about being a parent. And then that social anxiety can lead to even more isolation, because it may feel really hard to go and interact with people and might lead to avoiding interaction. As an extreme variation of this, postpartum PTSD, post-traumatic stress disorder, can occur after traumatic deliveries. I work with many parents whose infants have had extreme medical conditions and interventions, right, with often extraordinarily high risks to the child's health, right, that can feel extremely traumatizing to the parent. Okay, so two other variations of postpartum mood disorder. Postpartum OCD. What does that mean? So postpartum obsessive compulsive experiences, repetitive thoughts, intrusive thoughts, mental images, visual images that feel at the very least inappropriate, unwanted. Oh, I don't want to think about that. Sometimes even gruesome. And those repetitive thoughts or images might cause stress. Impulses, right? This is the compulsion piece of OCD. Impulses to do actions that might feel like they provide, oh, if I do this, it feels like it relieves some of the obsessive thoughts or images. So maybe there's some temporary relief, but ultimately it doesn't actually help the obsessive thoughts go away altogether. So about 9% of people who experience postpartum OCD, about 9% of postpartum parents experience some version of postpartum OCD. Of those folks, at least half also have postpartum depression. So we're talking about these different categories of postpartum mood disorders, but there are overlap, right? Like I said before about postpartum anxiety, most people with postpartum depression also have postpartum anxiety. The most severe postpartum mood disorder is postpartum psychosis. And this is often the postpartum mood disorder that ends up in the headlines of a newspaper because some tragedy has occurred. It's the most severe expression of a postpartum mood disorder because both suicide and infanticide are risks of the disease. Symptoms of postpartum psychosis usually show up. It could start within a few days to a few weeks after birth. And often how it first shows up is that the other people in the life of the birthing parent notice that it's really hard to communicate with the parent. The parent might seem like they're out of touch with reality, having extremely rapid mood swings, might even be hallucinating. Visual images, that's different than a thought, right? Like literally a hallucination, seeing things that are not there. Or auditory hallucinations, right? Voices that someone might experience as telling them what they should do. And that's when the parent and the child are most at risk for harm. All right, so you might be wondering, so then who is at risk for these postpartum mood disorders? Anyone. Anyone is at risk. So the newest data suggests that about 1 in 7 of women or birthing parents, as many as 1 in 10 of fathers or caregiving partners, develop some version of a postpartum mood disorder. That means about 500,000 people in this country alone every year. Now, we do know what puts any of us at higher risk is a previous history of anxiety or depression. Even without a previous history, if there have been experiences of heightened depression and anxiety during the pregnancy, a higher risk of developing the postpartum depression after birth. ADHD, even without a history of depression, also appears to carry a higher risk for developing a postpartum mood disorder. If you are somebody who by history has experienced pretty significant mood changes during your menstrual period, during the menstrual cycle, that puts you at higher risk, right? More sensitive to your hormonal changes. And folks who have had a pretty significant history of difficult reactions to sleep deprivation puts us at higher risk, right? And we're going to come back to sleep in just a little bit. Now, I mentioned about the ADHD. The highest risk for developing postpartum depression is among people who have histories of depression and anxiety. But again, even without those risks, women with ADHD have an increased risk of postpartum depression. We could spend the whole rest of today thinking about this, but there are a couple of articles that we're going to be sharing with you that really think about part of what's happening is that there is an increase in rates right now of first-time diagnosis of ADHD among adults, among birthing people, of childbearing age. And that's likely contributing also to being able to identify folks with ADHD who have developed postpartum depression. And as I was saying before, we really want to be sure to be remembering that's not just hormonal shifts, right? There are other psychosocial factors that increase risk, such as the pregnancy not being wanted, a history of trauma for one or both of the for the birthing parent and partner, lack of social supports, right? Family nearby, family that can be trusted and depended upon, friends, family, social circle, right? Lack of access to basic needs, lower socioeconomic status. So I probably don't need to say it, but I will. So therefore, all of the other inequities that we see in the healthcare outcomes for communities that historically have been under-resourced, communities of color, I said lower socioeconomic status, all have increased rates of postpartum mood disorders. All right, so what does this mean for us? What it means is that it's really important that we learn the signs for ourselves and each other, right? In our social relationships, in our professional relationships, right, with your care providers, to reduce the stigma and shame around postpartum mood disorders through universal screening, right? Universal screening, OBGYN, in pediatrics, in childcare, early care and education, internal medicine, mental health, right? As many places as a birthing parent and their partner interface with the system, even if it's multiple places that they're screening, getting that screening into place to improve access to early treatment. Catching symptoms early can prevent the more extreme, severe versions, right, of postpartum mood disorders. It's really important that birthing parents get clear and consistent messages from people in their lives and from society that this is not just something that's in their head. And that we as a society also need to be working on increased access for one or more of the major supports that are shown, that are proven to work in reducing the suffering associated with postpartum mood disorders. What are those factors? One-on-one mental health support, CBT, cognitive behavioral therapy, telehealth support, potential for medications, which I'm going to talk about in just a sec, and very importantly, support groups with peers. Time and again, we hear again and again and again from parents just how critically important it has been to connect with even at least one other parent who is experiencing or has experienced some of the same symptoms. A comment about medication. It's September 2023. We know that we are in the midst of something very interesting that's happening right now in the arena of medications for postpartum mood disorders. Historically, there are many medications that can adjust and reduce the suffering of depression and anxiety. And some of those medications are very appropriate for folks with postpartum mood disorders. There has been a medication that was specifically designed to treat very severe postpartum depression and psychotic depression. That was brexanolone, right? Then from there, what was developed was intravenous IV zuranolone. again, for the most severe expressions of postpartum mood disorder, and those IV had to be done inpatient or, in a clinic setting. Those medications are different than a different class of medication than the other medications, historically for depression and anxiety. The SSRI medications, right, working on brain chemistry. The medications like zuranolone, specifically for postpartum depression, target something different. It's actually designed to target hormone levels directly. Right now, we're all waiting with bated breath for zuranolone to be available in pill form, and that might happen as soon as next month. However, as much as that brings about some hope and some excitement, the idea that an OBGYN, a nurse wife practitioner, might be able to prescribe in order to, address a postpartum mood disorder. And of course, screening is still a major first step in the right direction to identify folks. It's also a major step in society that a pharmaceutics company has actually taken that step to research and produce a medication specifically geared around predominantly women. But we don't yet know whether the medication will be appropriate for everyone. We don't yet know about the expense and people's access to it through insurance. It is even more important for the cross-sector environment, right, to engage again in screening and then to make available both access and integration to mental health support. Access, what do I mean by that? Here in Massachusetts, there's a wonderful program called MCPAP for Moms, the Massachusetts Child Psychiatry Access Program, but for moms, which means that folks in primary care, if they are trying to assist a parent who is in their care, they can, through this program, access a consulting psychiatrist urgently, right, to help with the triage. That's an access model. Integrative models, that's where the mental health process is actually integrated into primary care or OBGYN. An OBGYN practice hires mental health folks to be working right in clinic with them, or primary care does the same. There's some really beautiful, very extensive integrated programs in different parts of the country. One at Columbia University, for example, called PrEP, Practical Resources for Effective Parenting, integrates mental health, physical health, peer support, group therapy, right? All within the same program. The Mother and Babies program at Northwestern University, the Rose program at Brown University. Those are all examples of integrated care. Okay, so coming back to this idea of postpartum depression or postpartum mood disorders occurring in context, we've got the baby in the middle of the system. Everything that's happening inside the baby's behavior and development is affecting everybody else in the system and vice versa. One of the reasons why we want to move so quickly to supporting the whole system for the benefit of the child and the benefit of the parents. What we don't want to do is separate out parenting from healing. What we know is that the neural pathways in our brains as adults that drive parenting, that drive attachment between us as adults and infants, those are the same neural pathways that can become negatively impacted or dysregulated by a postpartum mood disorder, right? In part because of hormones, but also in part because of lots of other factors. And so we really want to keep that infant-parent relationship at front and center of our interventions to really engage parents in active involvement in caregiving with the babies, right? I remember one mom telling me her postpartum depression now had gone on into her child being almost 2 years old. And what she was originally told was, well, the best thing you can do for your child is have somebody else take care of the child. Well, this went on for months and months and months. And this poor mom was devastated that she wasn't actively involved, right? Parents suffering from postpartum mood disorders need extra support for navigating the demands of their own healing process, but also navigating parenting. The stigma of not feeling competent, right, as a parent can really interfere with someone's comfort level in seeking out help. So that's why, again, we need screening at multiple times, not just once right after the baby is born. So let's take a look. Here's a baby, right, trying to self-regulate. They need assistance from their parent to do that. But the parent themselves, we as parents, can become dysregulated by the baby's dysregulation. So all parents need relationships with other adults to support them in feeling regulated themselves in order to help support the baby. And so part of healing in postpartum mood disorders includes using the baby's behavior for us as practitioners as the doorway into the system, right? Us being together with parents and their infants to have the baby's behavior offer up a pathway in our relationship to help bring baby and parent together into those very, very important experiences of discovering the real baby together and helping parents' brains actually move towards more healing that can come from those direct interactions that are supported through dyadic therapy and are supported through these moments of meeting, right? In early childhood, in that fourth trimester, there are many moments where the infant can be soothed and comforted to the point where they are very available for social engagement with their parent. And those moments are critical for new parents to experience so as to feel successful as a parent, so as to feel some of the love and the joy that they're entitled to. So, relationships, source of building development. Relationships, source of building resilience. And that's what we're here in service of, hope and resilience, by honoring culture, the cultural strengths and rights and rituals in families, and providing relationships where healing can take place. What do we mean by that? First and foremost, establishing safety. And yes, sometimes a parent with a severe postpartum mood disorder needs hospitalization. And yes, sometimes that does create a separation. But we want to reunite and heal that relationship as part of the healing process as much as possible and as quickly as possible. So finding at least one person to listen, to reflect upon your pain, the thoughts that have occurred, right? Finding that trusted person to be able to tell the story, right? Certainly within mental health treatment, but even on the road to getting there, finding peer support to sort through some of those more painful thoughts and emotions, and practicing self-regulation. What do we mean by that? How we manage our bodies, our feelings, our thoughts, and reactions, right? So those are critical pieces of the healing process to work with a professional and with peers to practice those self-regulation techniques in service of repairing relationships, because in the process of repairing the relationship with the child, the relationship can be stronger. And that ongoing self-care being critical throughout parenting for the rest of the life of the child and the parent together in relationship. So I just want to end on one note here. The importance of working with someone to help establish routines and rituals, engage in physical movement, activity, exercise, proper nutrition and hydration. These are all cornerstones of the healing process. Yes, sometimes medication, social connections, especially through support groups and like that stress management, mindfulness practices, and sleep. Okay, so here's one of my last messages about sleep. Often parents are told, we can't really try to help shape a child's sleep until they're about 12 weeks old. They've reached a certain weight or they've reached a certain age. I wish that every OBGYN practice started to talk about infant sleep before the baby was even born, because the routines, the rituals around helping a baby understand that it's bedtime, the baby can start to become accustomed to some of those routines and rituals as soon as they come back from the hospital. A soothing, same routine every night is helpful and soothing, not just to the baby, but to the parent, and can help the baby move towards longer stretches of sleep as soon as possible, which is a critical step in the parent's health and recovery, and that to help prevent the worsening symptoms of postpartum mood disorders that can be brought about by sleep deprivation. So I do want to pause there. And I know that we want to spend some time before we say goodbye on some reflections, some comments, some questions.
Thank you, Dr. Singer, for that, for helping us to understand and with such compassion. Before we start the Q&A, I'd like to thank Inflow once more for sponsoring this webinar. I'd also like to share the final results from today's poll questions. If you've experienced postpartum depression, were you given a diagnosis, or did your doctor miss your symptoms? 70% said their doctor missed the symptoms. 30% said they were diagnosed. And the second question was, would you be able to identify postpartum depression in yourself or in others close to you? 54% said yes. 42% said they weren't sure. Now to your questions. If you have postpartum depression with one child, are you likely to have it with subsequent births?
It's an excellent question. Yes, you're at increased risk, but not necessarily, right? So this is where it's very important to remember that that postpartum mood disorders are multifactorial, right? They're not just caused by hormonal dips, or not just caused by, oh, if I have a history of previous episodes of depression, including a postpartum depression, then I definitely will have one. There's all of those other psychosocial stressors, right? Maybe you know a little bit more about what it will feel like to have a crying infant, and have an infant who might cry for many hours, and put into place additional support. So it's not a done deal, right? It does put you at a little bit of a higher risk, yes. But recognizing those signs and symptoms in yourself earlier on, and again, finding at least one person who will listen. It's so distressing to hear those statistics, right, Carol? It's like, really? 70% missed? Like, no, that's the whole point. Screening, and then screening again, and screening again, right? most women don't see their OBGYN again after 6 weeks postpartum, right? So then it has to switch over to primary care. It has to switch over to pediatrics. Here in Massachusetts, we worked very hard on the Postpartum Depression Commission to put into place postpartum depression screening for parents enacted in pediatric practice, but it's certainly not universal.
Okay, thank you. We have so many good questions. I'm excited to get these to you. What is the best screening tool for postpartum depression? And how do you know when the baby blues turn into postpartum depression?
Okay, so let me start with the last part first. The baby blues, again, usually within the first week, usually subside within the next couple of weeks. If you're having anxiety, sadness, crying, tearfulness, lethargy, or even some of the more, intrusive kinds of thoughts, worries, beyond that first couple of weeks, for sure, contact your healthcare provider, either your OBGYN or your mental health provider if you have one. And in our next slide, oops, I'm sorry, I'm just going to go back to these resources because it's really important for folks to understand that there are ways to reach out individually, right? The postpartum support internationally, there for you 24/7. Carol, please remind me of the first part of the question. The second part was about postpartum blues.
Yeah. The first part was, what were the best screening tools?
Okay, so it's a great question. The Edinburgh is a screener, right, that has been historically used in a lot of research studies because it's research reliable, which is great. The only thing is that there are a lot of providers who hesitate to use it because there's so many questions that get pretty quickly about suicidality, et cetera. So I would think of it more as like a tiered process. There's something called the DAS, the Depression, Anxiety, Stress Screener, right? That's really excellent because it gets at, a number of different areas. The PH9, right? So something that's a little bit broad. And then if something shows up on that screener, going in deeper with another screener after that, if not, right, a more comprehensive interview.
Okay. Do women overcome postpartum depression without clinical assistance?
Sometimes, yeah. Sometimes they do. It's not necessary to suffer, right? We're very strong. We push those babies out of our bodies. But it doesn't mean that we need to suffer with the signs and symptoms of postpartum depression. So do some depressions resolve without treatment? Yeah. Do some postpartum depressions resolve without treatment? Yes. However, postpartum mood disorders can worsen. So my most important message today really is learning the signs and getting support as soon, as early as possible so that a postpartum anxiety, for example, doesn't become a postpartum OCD, so that a postpartum OCD doesn't become a postpartum psychotic depression, right? We don't want to wait and see. We want to get you the support.
Yeah, so I had some questions around clinicians and care. One was, how could we better educate doctors to the signs of postpartum depression so that they're recognized earlier and treated? But then what complicates that is if you're not seeing your OBGYN for 4 to 6 weeks after delivery, that's a lot of time where things can happen and develop.
Yes.
What are some ways that clinicians can intervene, or how can we sort of, use a stopgap in that 4 to 6 weeks or longer to catch these symptoms?
So again, the list of resources that I included a few slides ago, which I'm sure is going to be, posted and sent to you. Those are resources that any birthing parent or partner can reach out to, regardless of whether or not you have an appointment the next day or not, with your OBGYN or your nurse practitioner, or if you had a family doc. So your primary care is your first person to reach out to. If you're not screened, right, with a formal screener, to ask for one, to say, I am not okay. I don't feel like myself. This is not what I feel like, right? This is not what I expected to feel like. This is not what I feel like. What can we do as clinicians? We can do more of things like we're doing today, right? Meaning empowering folks in primary care to really feel comfortable reaching into the emotional health, mental health needs of their patients through increased access, through increased integration of behavioral health services, right? Because sometimes folks are afraid to ask because, well, what if the answer is yes? What do I do then, right? And that's where some of those resources like Postpartum Support International are so critical as resources, not just to individuals, but to clinicians themselves as well.
Okay. We had a question about the new pill that was approved recently for postpartum depression. Is it okay to take it while you're breastfeeding?
Okay, so I am a clinical psychologist. I'm not an OBGYN. So I am going to respectfully defer. That is a question that should always be asked and talked about with your medical provider, whether it's the new pill or the existing medications for depression and anxiety, because it's the same question. It's the same question about safety during pregnancy and safety during breastfeeding, and weighing the costs and benefits. If someone has a postpartum psychosis, it is critical that they get high intensity medical support. That is going to automatically beg a conversation about what to do about breastfeeding, right? But if the parent is suffering with suicidality, that level of safety has to be addressed first and foremost. And, thinking about breastfeeding, of course, but the health and the safety of that birthing parent has to be tended to right away. So I apologize if that was a little evasive. That's really a question that has to be asked and answered on a very individual basis for each birthing parent with their healthcare provider.
Yeah, that makes perfect sense. We have a question. Is there such a thing as postpartum adoption depression?
There is. It's such an excellent question. I really appreciate whoever just asked this question, because it highlights once again that hormone changes alone do not explain postpartum mood disorders, right? So let's say like the psychosocial factors. Let's say if we have a birthing parent, let's say we have a mom, we have a woman who has suffered many pregnancy losses en route to IVF, en route to IVF not being successful, en route to walking down the adoption pathway, and then finally has a child. Right? That is an enormous amount of stress, maybe even traumatizing level of stress that mom has experienced up until that point. And then along comes the baby where they think, oh, I'm going to finally feel so joyous and so grateful. And then find like, I'm not feeling the things that I thought I was going to feel. Right. Those are ingredients for a postpartum mood disorder, again, that deserve support, even though the same kinds of hormonal shifts are not taking place. But the sleep deprivation, right? All of the other pieces are
Sure.
there, which sleep deprivation itself can lead to depression.
Yeah. Yes. I remember that.
Mm-hmm.
Someone asked, is there a peak time that depression occurs after childbirth, or a time that more so than other times where it's particularly that you need to particularly watch for?
I would take the stand, and I have taken the stand, that screening should occur all through the first year postpartum. It is true that most postpartum depressions will show up within that first month after the baby is born, right? And so that's when there's usually more attention being paid. OBGYN, pediatrics, right? But there are people who don't develop the mood disorder until further on. That's where I come back to this idea about sleep, right? It's one thing to be sleep deprived for 3 weeks, for a month. It's a whole other thing to be sleep deprived for 6 months, 8 months, right? Which is why it's so critical to think about the infant and the parent together and to do some of that dyadic work. So some of that depression might not actually develop until several months after the baby is born. But for the most part, the onset is usually in the first few weeks. But if you remember, one of the things that I said earlier was that some of the statistics about the rates of postpartum mood disorders might be an underreport, because a lot of the studies only look at that first month postpartum, whereas I've certainly heard from plenty of parents that where they felt like they hit the wall was after the first half year of life. So really the vigilance throughout that first year.
Okay. And then our last question is, how does postpartum depression affect a new parent's ability to return to work?
Yeah. Oh, now we can get a whole conversation on whether our society adequately supports new parents or not. So that's a whole other webinar. So most parenting leave finishes potentially before a postpartum mood disorder has adequately healed. And so you have the risk of the postpartum mood disorder. And even if promotion, prevention, intervention, treatment are in place, then you have the added stress of separating from the baby when maybe the first, couple of months didn't feel like you had enough chance to feel connected. Right? That's an emotional insult. So separating from the baby, again, if there's sleep deprivation and everyone says, well, sleep when the baby sleeps. Well, you cannot do that if you get up and you go to work and you're separated from the baby. And then what if you're also pumping right? So this is why it is so critical to do the screening early and regularly. And to this viewer's question, especially when there's additional transitions on the horizon, a return to work, maybe a grandparent moved in for 2 or 3 weeks and now they're leaving. Maybe the parenting partner has returned to work, even if the birthing parent themselves hasn't. All of those transitions heighten the risk again, not because of the hormonal dip, but because of these other psychosocial factors, right?
So you can see how important support is.
Critical.
Mm-hmm. Yeah.
Critical. And I'm saying critical on purpose because our whole goal is to try to prevent postpartum mood disorders from worsening. Some of them are going to happen, right? You catch them early, they can be effectively treated with a combination, again, of one-on-one treatment, potentially medication, support group, and then a combination of those pillars, right? Self-care, sleep, hydration, food, social supports, right? And the mental health, treatment modalities of CBT, of mindfulness strategies, stress reduction, right? Like we do have effective tools, but parents can't do it by themselves, right? We can't expect parents, oh, I'm just going to completely monitor myself and then I'm going to go get the help I need. No, the whole support system needs to be aware that anyone is at risk and we need to screen more than once. We need to screen across sectors and we need to build in supports for as soon as and for as long as the parent feels the need. And for that, we need to reduce stigma and shame so that families don't feel as if, oh, everybody thinks I should be able to be doing this. So I'm afraid to ask for help.
Dr. Singer, this was such good and important information. Thank you so much for joining us today and for sharing your expertise with our ADHD community. We really appreciate it.
Well, thank you for having me. And I am of the firm belief that as there's more recognition of what the signs and symptoms are, so that birthing parents don't get dismissed like, oh, it's the baby blues, that more and more people will step forward to say, something's just not right. We all know when we just don't feel right. So back to your report, Carol, about the poll, would I recognize the signs? Well, I'm hoping that today we did talk about what some of those signs are: the tearfulness, the sadness, the lethargy, like I don't want to get out of bed, right? And even short of that, the anxiety, the intrusive thoughts, right? Worries that really interfere with the ability to carry on daily function. If those go on more than a few days, that's not just the baby blues. That deserves a multifaceted response.
Okay. Well, thank you again so much for all this important information. And thank you to today's listeners. We hope to see you again next week for our free webinar on the unique challenges that clinicians face when treating patients with depression. And make sure you don't miss future ADDitude webinars, articles, or research updates by signing up to receive our free email newsletters at additudemag.com/newsletters. Thank you, everyone. Have a great day.
Thank you.